So, good evening, everyone, and a very, very warm welcome to yet another learning session from Annie's Patient Safety Fellows. We are very glad and we are very proud of the fellows doing this sessions for the last, this is the third year. Every month we have any patient safety fellow coming here and sharing something that is related to patient safety. The topic are varied, and those who have not seen these episodes before, please visit Annie's YouTube channel and you will find all the recordings over there. So, a very, very warm welcome. And before I hand over to today's speaker, just give me a minute. So, let me start from the beginning. So, this learning sessions are brought by Annie Patient Safety Fellows. Annie Patient Safety Fellowship is a pride collaboration we have with Patient Safety Movement Foundation USA, and our fourth cohort patient safety fellows are doing the sessions this year, and it's a 2 year program where any patient safety fellows they apply the any members, then we shortlist, and then 6 to 7, sometimes 8 people they complete. The first year they do learning and sharing knowledge, etc. Second year they do mentor the next cohort. That's how it takes to. Very proud that they all had been doing great job, and I don't have to emphasize the fact that this is all for patient safety. We believe that all roads in healthcare will lead to patient safety. If it does not, something not right that we are doing. So the complete calendar has been published, and we will stick to those, topics. This year we have a combination of quality improvement projects, and there are also patient safety topics that is being, addressed this. So in the month of January, we had Mr. Abu Dayan presenting a quality improvement project on scripted communication. And this time we have Dr. Davinder Kaur, ANEI Patient Safety Fellow 24 to 26. She will be taking us through making early warning score work. The topic seems to have caught attention of many people because I was in one hospital today. So they were talking about, oh, today the session is about WS and we are going to join. That kind of tells that hospitals are aware of EWS, they have the process in place, but maybe it is not leading to complete patient safety as well. So I will leave that to Dr. Davinder to discuss. And next month, we have Professor Elizabeth Workey talking about intra-hospital transfer of patients on non-invasive ventilation. So this is a QIP. They have been part of the project. So we are bringing them once again so that can be dealt with in totality. So it goes without saying, ladies and gentlemen, a very, very special and warm welcome to Grand Hyatt Kochi, Kerala for our flagship annual conference ANEICON 2025 that is to be held on 30th and 31st of May in Gorson countries. See you all there. So let me play this little advertorial for all of you to enjoy the Indian music and inviting all of you to come to Kerala. So see you all at. And with that, thank you everyone for being here. ahead of time, and we have 70 plus people. That is really, really wonderful. It kind of, shows the commitment to each one of us towards patient safety. So, Dr. Devinder, a very, very warm welcome. You can introduce yourself, speak a little bit about current position, what you're doing, and then take us through your topic. And my request to everyone is please stay off the video and off the audio while Dr. Davinder is discussing, and please put your questions in the chat. And once the session is over, we can take the Q&A. And Dr. Davinder, it is 7:07. You can take 45, 50 minutes. Then we will spend a little time on any questions or any comments that the audience may have. And probably I may have some practical points to add to it. And somebody else also has that. We will use that few before we close up. Yes. Does that sound like a plan?
Yes, ma'am. So
Okay. You.
good evening, ma'am, and good evening, all the participants. So first of all, I give my regards and thanks to ma'am for this wonderful session. Ma'am always think very nice topics for the patient safety. They ultimately, our aim is to improve the quality of patient care, and that goes towards the patient safety. So thank you, ma'am, for this wonderful topic. This is very relevant topic for the patient safety. Let me share my style. So I am Dr. Davinder, working as Principal, Gyan Sagar College of Nursing, Rajpura, District Patiala, Punjab. I am working in this position for 2014 onwards. Prior to that, after my graduation, I worked at PGI MER Chandigarh as the sister grade 2 in the ICU. After my master's in 2000, I have worked in emergency department of PGI MER Chandigarh. And 2007 onwards, I am in the teaching. And along with this, I am looking after the critical areas of our own hospital because we have parent hospital attached with the medical college. So I have did my doctorate in the ICU patient in the prevention of CRBSI. So let's go to the topic. First, I will share my screen. Is it visible?
Yes. Yes, it is visible. Yep.
So this topic is very, very relevant, making early warning score work. So I think in the hospitals, we come across very patients. Patients are critically sick in the ICU, patients are sick in the wards. So early warning score, if we check the patients while we are looking after the patient along with their very important, we can say vital signs, so we can prevent the mortality and shifting of patient to the critical care unit. So what is the introduction when it was started? So early warning score is a quick and simple physiological scoring system that assigns the clinical deterioration based on the specific vital signs. There are the six, we can say, systolic blood pressure, heart rate, respiratory rate, temperature, and conscious assessment. So early warning score, sometimes we call it a track and trigger system because we track the changes in the vital signs, and ultimately it trigger our clinical assessment, and then we can take care of the patient. Accordingly, we can just increase our monitoring at the intervals, and we can promptly take care of the patient prior to it go to the adverse events. So how it was started? So it was started EWS in the 1997 in Sampezit University Hospital in the Norfolk, England. So after the National Institute for Health and Clinical Excellence, they have just use of early warning systems to monitor all the adult patients in the acute hospital setting in 2007 guidelines. So after that, in 2012, the Royal College of Physicians, they created a national early warning score that could be implemented across the national health services. So this is called the National Health Services. They have used it as a to monitoring the patient as the national level. So in 2017, it was modified. They added vital sign weightage because prior to that, vital sign was monitoring, weightage was not there, and confusion as a bedside measure And a separate oxygen saturation scale was also implemented along with the if the patient has type 2 respiratory failure, because sometime in the COPD we don't consider as a SpO2, but that time they added the separate parameter that we have to monitor. So in the Dutch people, they have just started one individualized early warning score system was developed in 2018. So what they say that along with this is just the modification of the news, the like national warnings, early warning score, and they added that as per nurses' experience, they should give some weightage, and they can just change the score according to the individual patients. But it's not workable because it's dependent upon the experience of the nurses. So mainly in all the countries, we can say at the world level, only the national early warning system is we are adopting every hospital. So why we should use? Like we are using this, then why we have to use the first thing, track and trigger system? That I have already told, track and trigger, because while monitoring the patient, when we are recording the patient, we have to track the early changes. And according to that, when it trigger, we estimate the risk of deterioration. So it assists clinicians in recognizing and responding to patient deterioration at and earlier stages of the progress, because we already know when patient is sick in the wards we monitor the patient, but in wards we do monitoring at the different intervals, the vital signs. Some hospital they have the protocol that they monitor the vital signs at 6 hours interval, some do it a patient is stable 12 hours, 4 hours, 2 hours. So accordingly, if we use this early warning score, earlier we can recognize and respond to the patient deterioration, that accordingly if we track any changes, we can increase the frequency of that monitoring. And it early recognition improve the patient care outcome. So if we say what are the patient care outcome is the recovery of the patient. Otherwise patient will be deteriorate, we will not be able to observe the patient and we can't respond promptly to the patient, because if we monitor and we have not considered this parameter is altered, we don't bother that parameter. But if we use this early warning score, so immediately every time we just have the graphical presentation and we can see, okay, these are the changing, it goes to from 0 score to 1 score or the 2 score, that we will discuss further. So accordingly we can recognize and we can improve the patient outcome. So what are the purposes? So if we go for the purposes, they have the primary goal. What is the primary goal for that? It gives us standardized communication and escalation protocols, because it's already standardized protocols are there. They are used at the national level. So according to that standard, we have to just do the marking. Yes, you have to give the scores. Otherwise, every person can say, okay, I can give 1 or 2. So variation will be there. So these are the standardized communication at all levels of medical care team. So it reduced in the adverse events such as the cardiac arrest or the ICU admissions. Because sometime in wards, in the general wards, we can say, and the other wards like in the OBS units and the pediatric units, we don't take that events in promptly. And that time, if you don't take care of the patient hemodynamically, we can say the if the patient is not breathing properly, the first over vital sign we can say that changes the respiration. Sometime while checking the vital signs, what we do, we take the blood pressure and we check the SpO2. Sometimes we don't calculate the pulse. And sometimes we see, okay, patient is okay, we don't calculate the respiration because we consider. And that changes, we are not tracking them. And if we track them at the time, then we can reduce the adverse events that can occur. That is the like last patient can go into cardiac arrest or it can go to the ICU. Admissions can be done. Otherwise, because we don't do that. So what is the impact on patient safety? It supports proactive care rather than the reactive care. Like if we track the changes, we have the trigger system, and at the time prior to the adverse events, we can just report to the rapid response teams. They can take care of the patient. We can monitor the patient more frequently. So proactive care can be done. Okay, patient is deteriorating, this has to be done. Patient have the altered respiration, maybe we have to from room air, patient is not breathing properly in the room air, and we can put the patient on the oxygen mask. So otherwise this is, and ultimately The reactive care that patient will have the when there is a changes in the ABG, otherwise that time we will take care of it. Then it enhances the multidisciplinary teamwork, because in the multidisciplinary team we have the bedside nurses, we have the ward in charge, we have the doctors, we have the different therapists that we are working in that. So it enhances, because every hospital they have the rapid response team to nurse. They know if there are changes, this is the thing, these are the alteration we see in the these charts, and we take the help of all the team members. And what is the ultimate aim? We have to save the life of the patient prior to irreversible changes that occur in the patient. So main how it work, very important, early detection and response to patient deterioration to avoid adverse events that I have already prevent the morbidity, cardiac arrest, ICU admissions, and the mortality. And this I have already told, display indications of clinical deterioration up to 24 hours before there is significant clinical event that occurs. Like main, the first thing that we get the alteration in the parameter, that's the respiration. And many researchers, they have proved that respiration is the most neglected vital sign that we don't check properly. Because sometime when we check the SpO2, that time we see the heart rate, and heart rate is there, we don't check count the respiration for the patient, and we just mark it, okay, patient is looking okay, we can do that. So clinical deterioration is not observable. Like if you have not checked the pulse for the patient, we have just checked from the SpO2, okay, it's 80, we can write. But if patient have any arrhythmias, so we will not check the rate and rhythm of the that pulse. And sometimes if patient have the weak pulse, we can immediately see, okay, maybe patient is getting the hypoperfusion. So we have to check for that parameters. But if we don't check, early warning score is not workable in a hospital. We just do by looking at the patient. So patient will be deteriorated, and we will not be able to observe it. To do that, early warning score is very, very important, that every nurse has to do it in proper way after really assessing the patient's vital parameters that we can say. And failure to manage this deterioration appropriately leads to the negative patient outcome that I have told. If we will not manage, if we don't check the pulse rhythm and everything, ultimately patient will go into that. Hyperfusion will be there, and ultimately patient will have the less urine output. You have not checked the respiration, patient not breathing, ultimately there are changes in the pH of the blood, and ultimately there is alteration in the ABG, patient will go into metabolic alkalosis, respiratory alkalosis, the different things. When it go, then we have to take the prompt action. Sometimes we have to shift the patient to the ICU, patient needs intubation, because we have not monitored at the initial level. So this early warning score is very important to detect the patient prior to reactive care. Then we have to do to prevent the deterioration, so that we can prevent the morbidity. So what is the key components? What it has to be there? It's validated criteria. This I have already told. This is evidence-based parameters with clearly thresholds. So many researches has been done where they have seen all the parameters that we are using in the early warning score. What is their threshold? How they are affecting the patients, and which way they affect the patient for the improvement. And it's very easy to use. Simple scoring system is there. Their nurses can just in we can say, in spite of the simple vital sign chart, they can use it, because it's very clearly depicted when we have to give what score. Then integration, seamless connection with electronic health records and the real-time alerting methods are there, because now the innovations are so many. There are science is taking charge, and many hospitals, they are using the electronic health records. They have the real-time alert system is there, because even in the monitors we have seen, sometimes we have set the limits and they give the alarm, they give the alerts. So we have to respond that alarm system limits that we have to integrated while using the this EWS. Then education and training. This is also very important key component, because regular sessions has to ensure the competency. When we are using this, ultimately quality checks has to be there, whether we are using this EWS according to the proper way, if there is any deficiency, nurses are not able to do it. Time to time, training has to be given. Newly appointed nurses, we have to train them how to use it. So this should be the continuous process that has to be used. And feedback mechanism, very important. Continuous monitoring and update based upon the clinical parameters, and ultimately in the hospital we should do some outcome researches. That time we can say, okay, if we have used this EWS for this patient, whether we will able to prevent the shifting of patient to the ICU, and how these system has have helped the nursing services and for the patient recovery and for the morbidity and mortality of the patient can be able to prevent it. Sometimes many researches they have found, like while using this feedback mechanism, they seen, okay, so ultimately mortality rate of the patient is not affected, but the initiation of rapid response teams has been more, because nurses are vigilant. They are making use of effectively use this early warning score, and ultimately when then they track any changes in the early warning score, immediately they initiate the rapid response teams, and ultimately they can have. So early warning score, so what we have to identify? Deterioration, I will say it's the score is 0 to 20. So main 0 is the patient is normal. If score is more, the score is 3 to more, then we have to do the rapid assessment of the patient, and accordingly we can do some interventions. And what it does, it will prevent the deterioration and the imminent collapse, and prevent the ICU patients, to reduce the mortality and morbidity in the patients. So this is the brief, we can say, the theoretical background of the early warning score. So there are some tools. Can can you please tell me what are the different early warning scores that are available in the hospitals? You can
News,
write in you
views.
can write in the are using these scores, participants? You can contribute.
You can write in the chat box. News, pews, muse, all the U's are coming. Muse, pews. Okay.
Okay. Okay, ma'am. So these are the Muse is modified early warning score. Muse is the national early warning score. Muse is the pediatric early warning score, and Muse is the modified early obstetrical warning score. If you see, there are the four type of scales. Why there are four type of scales? Why there are four type of the different scales are there? Ultimately, the six parameters we observe. Can you please write in the text box?
Someone can unmute and talk also why there are four different, you know, early warning scores. Okay. Somebody wrote here according to age. That is half
Yes,
correct. According to age, half correct.
this is our part. Yes, true, ma'am. Because if we say it's why it's four time, because modified early warning score and national early warning score, this is almost, we can say, the same, because pediatric patients, they have the different set of parameters, like vital parameters, because their heart rate normal variations according to the age is there. And like 0 to 3 months baby has the different parameters, 3 to 6 is different, and pediatric patients has different. And if you go for the obstetrical warning scores, because antenatal time the parameters are different, after the delivery we can say the postnatal period, because we have to take care of the postpartum hemorrhage, so parameters are different. So that's why it's not there that one national early warning score can be used for the OBS patient and can be used for the pediatric patient. We can discuss one by one. So these are the main parameters that we can see. Like there are the parameter: respiratory rate, heart rate, systolic blood pressure, temperature, and level of consciousness. And this is alert. This is to the voice, to the pain, and unresponsive patient. Accordingly, we have to do the color coding. According, you can give the score. Like 0 score, a patient has a normal breath rate. Patient have the heart rate is this 51 to 100 beats per minute. blood pressure is 101 to 199 mm of Hg, and this is the temperature. So accordingly, this will be considered as the normal. So when we have to give one score when it's 15 to 20, score 2 when it increases, then score 3. So you can see the variation in the parameters. So according to, if patient have the within normal these vital parameters, we have to give the score 0. If 0, patient is alert, responding to you, and if patient is respond to voice, we have to give score 2. If patient is respond to pain or unresponsive, you have to give the score 3. So 0 to 4 is the low risk, routine observation is required. They have specified. 5 to 6, there is a medium risk, increase the frequency of monitoring. Like if you are monitoring the patient 4 hourly, then you have to monitor the patient 1 hourly. More than 7, high risk, urgent review by the critical care team or the rapid response team, whatever is working in your hospital. So this type of charts are available. Okay, so in this chart, if you look at this is the score range that I have told you. 0, the hemodynamically stable. It means patient is stable, and if it's 1 to 4, we can say observe and monitor the patient 4 hourly. If it's in 5 to 6 score ranges, this is monitor hourly and inform. More than 7, then continuous monitoring and initiate the rapid response team. So in this, you can see on this line, there is the parameter. Both the side, they have given the parameter. So it will be very easy to just fill the scores. We can say whatever the readings we will get from the patient, like record as a graph. Like this is for the first is the respiratory rate. So you have to see if your patient has a respiratory rate, we can say between 60. We have to write on this 12 to in between this column. You have to write into the corresponding box, we can say. You have write the value. So accordingly, if less than 8, then again is alert. It means patient is not breathing properly. If 9 to 11, we consider it. 9 to consider is also 1 point down. We can do that. So 12 to 20 is the normal range. We can do this. Then 21 to 24 and more than 25. This is the red category. Red is just, then we have to, this patient is continuously monitoring is required. Then we can go for the temperature, record as graph. 102, 101. So this is in the Fahrenheit, or if you are using the centigrade scale, accordingly you have to use it, because based upon that, some has the different type of this graphing. Otherwise, this color coding and score is, this is, it can be used in every hospital. Then heart rate, we can say, then systolic blood pressure, diastolic blood pressure, and this is the neuro response. So we can say alert to voice, to pain, and the unresponsive. And in this column, we have to do the total score. Like if you have given patient has heart rate is, we can say this respiration rate is 16, then patient has oxygen saturation is 96, so it will be 0. Then patient has the normal systolic, this temperature is, we can say 99 or 98.4. Then we have the heart rate. So heart rate is for this, we can say between the 72. Then patient have the systolic blood pressure, maybe it's 120. So accordingly, you have to calculate how much score you have given patient belong to which category, and ultimately you have to do the total score. And then you can also write the chest pain, uncontrolled bleeding, and prolonged seizure a patient have. Even some hospital, they have used these parameters also. And you have to include the intake and RT feed, IV fluid, urine, stool, and the weight of the patient. And after that, you have to do your initials, the person who has recorded that. So again, a patient is not patient on the, some oxygen supplementation has been given. So you have to report, like patient is room air, you can write RA, patient is breathing, patient have the oxygen mask, patient has the this humidified high frequency nasal cannula, CPAP, BiPAP. So all the things you have to just do the tick mark. So this is for the National Early Warning Score. So again, they have the parameters 0, 1, 2, and 3. Respiratory rate, you can see the variations, saturation, supplement oxygen, no. And if there is a yes, then you have to specify. Temperature and the systolic blood pressure. So SpO2 is also very important. A patient has the chronic hypercapnic respiratory failure, like in case of the COPD patients. So then And in this also, there is a heart rate and level of consciousness is also very important. So you can see these parameters are very important and we have to monitor that. These are the scores. Accordingly, the graph is there and you have to just do the scoring according to that. It's already mentioned, like white color, red color, red color. So accordingly, you have to just do the whatever the reading will come while checking the patient's vital parameters, you have to record in that. So after that, you can see this is for the OBS patients. These are the parameter. You can see they have the white, yellow, and the red zone. So they have the different respiratory rate, oxygen saturation, then temperature. These parameters are the same. Systolic, diastolic pressure. So what is included? They have included proteinuria, color of proteinuria. A patient is antenatal and we consider patient is having the risk of preeclampsia or eclampsia. That time you have to check for the proteins in the urine. And color of liquid, because sometimes patient, while checking the antenatal period, patient may have the meconium stain. You have to see if patient has a rupture of membranes. You have to see that. Then neural response, of course, the alert same that we use for all the patient, ABPU scale. Then a patient is postnatal, that we have to check for the look. It's healthy, it's heavy or false smell, that we have to see, and the general condition of the patients. So for that, you can get this type of chart. So if that part is not mentioned, like antenatal, postnatal, the same graph will be available. So every chart has given the score key. White is 0 score, green is 1, yellow is 2, and pink is 3. So accordingly, they have written 0, hemodynamically stable, 1 to 4, observe and monitor minimum of 4 hourly, 5 to 6, 1 hourly. So this is handy guide is available on every performer that you will see. Because if sometime we forget, we can just see the description. Accordingly, we have to do that. Hospital days, post-operative or postnatal days, date and time. And accordingly, you will see the similar type of these readings are there. And whatever rate you will count, and you have to just enter in each shift. Like 4 hourly, you have to put the time, like suppose it's 10 a.m. or it's 27th, date and time, and you have to do the recording. Okay, see neuro response, then lochia, looks unwell, score. Then if antenatal, fetal heart sound, and if patient have seizure, you have to do the tick mark. And if the patient has passes the urine, again you have to do that. And ultimately, the head nurse or the nurse officer that you have to do it. This is for the, we can say, POs, sorry, MIOS. So early warning score for the pediatric. So in pediatric, the scale is different. Why? Because in pediatric patients, because the behavior of the child is also bad. Because if 0 to 3 months, sometimes some parameters is not able to, we can monitor. So what are the main 3 parameters that has to be included only in the PU's behavior, cardiovascular status, and the respiratory rate? This is CRT is the capillary refill time. Because if the capillary refill time increases, it means there are the chances of hyperperfusion. Okay, so for that, like if behavior is normal, child is playing normal, so it's 0, irritable, 1, lethargic, and confused 2, and the unresponsive is the 3. So in the cardiovascular, you can see there are the different set, like baby spike or capillary refill between 1 to 2 seconds is normal. Its 0 score has to be given. For the tachycardia, if the tachycardia is normal value, 10% for that. If capillary refill time, 3 seconds, and second tachycardia of 20 above the normal rate. What is the normal rate for that age? Accordingly, if there is a 20, more than 20, suppose is the, we can say the 130 and it's 150, then we can consider as a 2. And for tachycardia 30, above the normal rate. Whatever rate is according to standard guidelines, what is the normal rate for that age group of pediatric, that has to be considered. For the respiratory rate, so normal rate is 1. It's not there only we consider the rate. We also consider how they use the respiratory muscles, because in children, the use of respiratory muscles and movement of the chest, it has to be taken care. Like for normal, no retractions and on the room air. If it's more than, what is the parameter? Suppose it's the 30 and baby has the more than 10, we can say the 40 respiratory rate, and using the accessory muscles with mild contractions, and patient is on room air with 30% FiO2 or up to 2 liters per minute oxygen is getting. And for the two, you can say moderate tachypnea and swab 20 normal parameters, and nasal flaring is there, and patient has the retractions. And patient is FiO2 now from 30, room air 30, now it's the 40, and oxygen is the 4 liters per minute. 3, if it's 50% FiO2 or 5 liters of oxygen, is grunting and apnea is available. So these parameters are different as compared to the news. So these are the, you can see the charts. So this is for age group 0 to 3. So they have given the normal ray. You can see the difference is there. Like it's 31 to 60 is the white. So white is the 0. For, so they, you have seen respiratory rate, respiratory effort, where there you can use the, like we have seen the retraction of muscles, that we have to be included. Then oxygen per liter, because we have considered whether baby is on room air, and if it's on the oxygen, how much oxygen is delivering, and what is the FiO2. Then we can consider the saturation. So write in the what is the corresponding rate that you have to see. So if the heart rate, again heart rate, if it's less than 40, you have to just consider the AAR team has to be, this rapid response team has to be called off. Then capillary refill time, I have already told, less than 2 or more than 2, there are the indications. Then alert, voice, pain and responsive, this is also there. Then comes the temperature, blood pressure if it's applicable. Then you can use the monitor, then intake output, weight of the baby, and urine and stool. Okay, so it's 1 ml per kg per hour. That has to be considered for the this neonate. Accordingly, the nursing sister has to do the science, and this scale is there 0. Then this score is between 0 to 1, observe and monitor 4 hourly. It's 3 to 6, monitor hourly, and inform it's more than 7, then response, rapid response teams has to be informed. So this is for the age group, we can say for the 4 to 6 months. Then these are the parameters, the range of parameters has been altered, and this is for the different, this is for the 1 to 4 years. And the parameter, you can say the level, that now it's 20 to 40 if the child is between the 1 to 4 years. So what is the normal specific parameters has given? So accordingly, these values has been changed and scoring has been changed. Then for the above the 12 years, because 12 years, 15 to 20, because we consider this is the normal adult type, the rate is there. So you can change this, changes this parameter rate has been changed. So normal, mild, severe, moderate pressure. So these are the same parameter rate. Then respiratory efforts, oxygen therapy. Then we can say the heart rate, capillary refill time, neuro response, because in the POs, this has been not changed. Like the parameters are same, but the range where we have to give the score, that's different according to every age group. So have you understood about how to fill these scores? Participants, please tell me. Or should I repeat, or I will proceed? Hello?
We can proceed, Davinder, and we'll take the questions in the end. Okay.
Okay. So now there is a one, we can say that comparison is there. So what compare, there are the different score scales, we can say the EWS is used in the different system, and the same 6 parameters are same, but they can vary according to that. Like views, we can say this is one parameter where we can use, and then news 2, then Hamilton emergency, early warning score, then Pews, then this is the for the tries, early warning score, tries in emergency. So these are the, if the different areas they have specified like ICU, medical ward, these are the same. So what is the difference? While in all the scales we can see the heart rate, respiration rate, systolic blood pressure, SpO2, supplement oxygen, temperature, and this alert scale, this is same for all the input categories. And what is the output categories? We can wear mortality and length of stay in the hospital. But for the news, cardiopulmonary rest can be the further that we have to see. But in this pediatric ward, we can say the behavior, the cardiovascular system, then respiratory system, and respiratory rate, we have included the work of breathing, while in the other adult patients, we have not included the work of breathing. So this is the main input criteria that's different between the different scale. This is for give the more clarity, like for the emergency department, if we use the triage and emergency early warning score, so this is different, and it check only the mortality. It's not check the early warning score. So this is the main, we can say, the differentiation slide that you can say between the different scores. So now we have some case presentations. Like if the 65 years old male is admitted to the hospital for management of pneumonia. During a routine check, the nurse observed the following vital signs. Respiratory rate is 24 breaths per minute. Heart rate is 115 beats per minute. Systolic blood pressure is 92 mm of Hg. And temperature is 37.80 centigrade. And level of consciousness, patient is alert at the time of the admission. So now we have to calculate the early warning score. So you have seen the respiratory rate, 24 breaths per minute. What score we have to give? 2. Heart rate, this 115 beats per minute, score is 2. Systolic blood pressure, 2. Temperature 37.8 is the 0, and patient is alert, we have to give. So how much is the score? So you can write down. So it's the score is medium to high risk score is the 6. So if you have that type of case came to the emergency, we can say, and we have calculated the early warning score. So case interpretation, so patient is required increase monitoring frequency every 1 to 2 hours because score is 6, and urgent medical review possibly by the critical care outreach team, and immediate interventions where that what we can do, the oxygen therapy, IV fluids, or escalation to intensive care, or depending upon our clinical assessment. And for the next case presentation, there are one more case. The 65 years old male arrived in the hospital with increasing shortness of breath. She has no chest pain, past history of MI, and was awaiting coronary artery bypass graft. He was also a known asthmatic. On arrival in the hospital, the nurse observed the following vital signs. Respiratory rate 30, heart rate 130, blood pressure 108/60, and temperature is 38.5. So now you can calculate your early warning scores. So what it should be? Can you tell? And level of consciousness is the alert. Sorry, I missed the one parameter.
They're writing 6.
So this is 5. So what has to be done then? So in the initial treatment, we have observed the score. So what the initial treatment? Because we have given the salbutamol nebulizer and oxygen therapy was given to the patient. So after 15 minutes, nurse has observed all clinical observation. He looked better. Respiratory rate 24, pulse rate 124, and BP was 95/55. And temperature remained the same. So score increased to 6. So patient was admitted to high dependency unit for observation and treatment. And after 50 minutes, it looked better. But again, patient was diagnosed after 50 minutes when they have checked, because score was 6. They have considered it as 5. So patient was deteriorated and patient was diagnosed with the septic shock from a chest infection. So what is the inferences? The subjective judgment made on the appearance only can be misleading. More objective judgment is often required based upon the physiological parameters. So main how it works, like from the two case presentation case studies, we can say when the patient come to us or in the ward, when we take over of the patient according to time, when we have to calculate this early warning score, the bedside we have to assess the vital signs, heart rate, we have to check the pulse, blood pressure, respiratory rate, we have to calculate temperature and the SpO2 and assess the clinical parameter need for supplement oxygen and the mental status. Then we have to calculate predetermined values assigned to each vital sign, calculate the aggregated score. It can be manually or automatically if you have the electronic health records that have the alerting system is already there. Then we have to assess the score against the escalation criteria, like criteria determine whether score exceeds the threshold or the escalation of air is required, because we have seen if it's more than 7, we have to initiate the rapid response teams. Okay, so that has to be there. Then what is the important outcome that we can have to really act on that? Option for that: repeat vital sign more frequently, like you have seen the first is 4 hourly, then its frequency change to 1 to 2 hourly, then immediately every time we have to check. Contact the on-call physician to assess the patient, or you have to activate the rapid response teams, and you have to transfer the patient. So you can see what is the basic. We have to assess, then we have to calculate, then we have to check according there is a change or there is a escalation of the criteria. Then we have to do for the category like 0, then we can say this is for the 0 score, then you have to go for the next score, then we have to go for the more than 7. So what is the role of multidisciplinary teams? Who should be involved? Nurses, physician, IT specialist, and the quality improvement teams. These are the 4 very important team members that has to be used. The frontier user of the emergency warning score, physicians for decision makers for interventions, then IT specialist ensure proper if you are using the electronic health records, because they are giving the proper readings, their calibration is very important. Then quality assurance team, because they have to monitor and refine the processes and see why it's not working, what are the deficiencies, because they can act promptly on those parameters. So shared responsibility enhances adherence and sustainability. A diverse perspective lead to the more reversed implementation. So ultimately we have to share the responsibility and perspective so that we can do the help the patient, and it can prevent the early, we can say, the morbidity, mortality, and admissions to the ICUs. So what are the challenges? If we see these are the system, the early warning score is working in the hospital. So what are the challenges that it affects the use of that? Incomplete adoption by the staff. This is very, very important. Sometimes staff is not aware what is the importance. Like after check the vital signs, after check the parameters, 6 parameters, then we have to just fill the columns and we have to do the graph charting, and then we have to calculate, because sometimes they don't adopt in the, there are so many reasons, maybe the workload, they are not trained, they don't feel what is the importance of giving this score. So lack of training is the one part that's there. Overreliance on the score. Sometimes overly we can just ignore the clinical judgment. Just we look at the parameters on the monitor and accordingly we do that. Then alert fatigue. Sometime in the hospital critical unit, this is very important. We have the alert fatigue. So high false outcome rates leading to the desensitization. We don't give attention to the what is the alarming system. This is very, very happening, because sometimes we fed up and just without looking at the monitor, without looking, considering that changes in the parameter, we just press the silence button on that. Then data accuracy, errors or missing the vital signs input, and overflow integration issues, difficulty signing the this early warning score with existing processes and the EHR. These are the main challenges that exist in our day-to-day working. So what is the future of this early warning systems? AI and predictive analytics use machine learning to refine and personalize the scores. This is coming up. Many hospitals taking the help of AIs in the wards. Maybe maybe you have this type of setup in your critical care units. So it's taking care of that. And remote monitoring, leverage wearable devices for continuous data collection. I think everybody using nowadays this. Even we can sometime in the future we can give this to the patient. We should just get the first information from the patient instead of looking at the monitors. Then personalized medicine, well individualized thresholds based upon the patient history and the respective, because like in the current medicine, one treatment fits all. We use one treatment that would fit to all. But in the future medicine, they will consider the patient, the different lab values, and accordingly that can see the effect. Otherwise, then patient will be more get the effect as compared to the one, because personalized individualized patient care is the main emphasis nowadays in the patient care for improve the quality and to improve the patient safety goals. Then interoperability ensure systems that can communicate across different platforms and the care setting. This is coming up, telemedicine, telenursing, telehealth. This is very important. This is also the future of early warning systems. So main at the, we can say for that conclusion, what we have read, the education of the nurses, how to do the monitoring, how to recognize the early warning scores, triggers we have to identify, then we have to take the help for help, either rapid response teams or your critical care team members, then this is the response. Like this same chain of prevention we used for the BLS, same is also for the early warning score that can be used. Education, we have to equipped with the knowledge, monitor, recognize, call for help and the response. So for conclusion, we can say the early warning score encourages nurses not to reduce complex medical situations to a number, but to take holistic patient-centered approach. Nurses should use clinical judgment, physiological knowledge, and patient-centered decision-making for their patient. And combination of both clinical assessment and scoring system is essential in detecting a deteriorating patients. So nurses can help prevent deterioration in patients if they know what to look for and when. This is very important. Nurses are very important team member, so they should know what they have to see and when they have to see. If we consider, if you know what we have to do and when we have to do, so it can save the thousands of patients, because it can prevent mortality, it can prevent morbidity, and it can prevent the expenditure of patient and help in the quick recovery of the patients. So this is all about the early warning score. These are the references. There's so many videos are also available on the YouTube where you can see how to fill these early warning scores. It's given by the NHS also. And thank you so much.
Thank you, Dr. Devinder. Maybe we can stop sharing. And if any questions from the audience, yes, if we can answer, it will be nice. Please go ahead in case you have any questions or comments. We have got 140 participants sitting here and listening to the lecture. So, uh, anybody has got any comment or any questions, please. You may like to add because you have got experience with EWS. So, I would like to pose a question to all of you that you all are using EWS, Muse, and Pews, and Trews, and Trews are things that I have not heard before. I would like to know that what are the challenges when you are actually using EWS for your patient? What are the challenges? Practically, what are the problems? Is it really helping, or sometimes does it fail to work, or it is just like the earlier graphs? People used to just put, you know, dots into the graph and, just leave it like a record. We would like to hear from the people in hospitals. Anyone would like to share something? It's surprising that our nurses don't have much to share. Those who are in hospital, would you like to share some real scenario? Anyone working in hospital would like to say what is your experience with the EWS? What are the challenges that you face? These kind of sessions must be used effectively by the participants. Uh, Nice to say, nice presentation, lot of new things introduced. But what is it that you're going to take back? Informative session, very good. But what are the practical challenges? That also must be discussed, no?
Yes, ma'am.
Can I?
Yes, yes, please go ahead.
Yeah, I'm Pramila here from Star Hospitals, Hyderabad, Manakram Guda.
Yeah.
Usually, whenever we see any patient is getting deteriorated and shifted to ICUs, when we check back the new score, they just write routinely. The staff doesn't understand, few of them, the importance of new score monitoring. That
Hmm.
is nothing but early warning score. And when
Yes.
we go back and do deep RCA, then we come to know that the patient is already landing up in the position, but the nurses are not able to understand and make it as a it's a complex situation, and we need to take a call that the nurses doesn't bother to come forward and tell that boldly. They just
Okay.
routinely, as they are busy with their work, routinely they go. And
Hmm.
at the last minute, when patient is feeling SOB, then they will realize that, oh, later part when we do the deep RCA, then we come to know that there's a patient's deterioration is there, but our nurses miss to grab that all the details correctly. That's what we face as a nursing heads when we sit in the boardroom, when we talk about during the CPR committee and all, how many met calls we have raised. When we look at back and we analyze the files, then we come to know that there are a lot of nurses who doesn't understand the news score properly to monitor. Then again, we keep checking, we keep teaching them, and we do audits also in between how they are capturing and all this is a big challenge for the nursing heads and the educators whoever is taking up this role. How much ever we teach, they make mistakes, and we try to teach them, and they learn, they leave, and other batch will come. So it's a continuous problem and process for the nursing heads and the educators. It's a challenging problem, and nurses should take responsibility to learn that, which we feel.
Okay, I think point well articulated, Pramila. I think, see, one of the solution, nurses will come and go, but the patients are always there.
Yes.
One of the things that I have seen is probably a session like this, it's like a very informative session, and it's very difficult to build in practice into an hour of webinar. So when we introduced the early warning score long time ago, I told them something. The number that you are putting in your paper on the scale, there is color, right? White, green, orange, red. I said, if your pen is sitting in the white part, okay, I'm okay. You're not doing anything. But if your pen is touching any other color, if you are not able to make out what is the story, please talk to your in charge immediately. My pen is documenting in the yellow part or the orange part or the red part. This is very important that they should understand. There are two things that, Dr. Davinder mentioned, the numbers that we get and the condition of the patient. But I think the understanding the condition of the patient was definitely a challenge. The EWS actually became a very good tool. You really don't have to use lot of your brain power to take the vital signs and put it on the graph. And when you put it on the graph, I think you can teach that to anyone with little brain. That if you are writing something in this color, this is what you should do. This is the number, the total number. It's not a very complicated thing. If you are working in triage, understand the truths very well. One way of getting people to do is just giving them scenarios and also asking them to document and then do a simulation, right? Do a simulation where they are going to document and they are going to ask someone, get a group of people. See, giving theory is important. They understand, they'll say it was a good session. But as Pramila said, actual life, it is not that. We try to understand what happened. RCA is throwing the evidence that the patient's condition was deteriorating, but there was no escalation. So, is it because nurses are pretty automatic putting, their numbers? Just give me 1 second. I'm sorry, there was some background noise coming. Whether they failed to escalate or they were just blindly doing it. So it's no not only do RCA when a patient is not escalated, but keep looking at your practices of documenting in the EWS. I also would like practically, I would also suggest that make your EWS the primary document for all vitals. Don't have them right here, right there. Then it is too much of work. You know, I've seen in one hospital there is old vital signs, then there is EWS. So they have to write in multiple papers. Maybe that, I don't know whether it is still existing like that. These are for the leaders to see that the documentation is in one place and it's very simple. It's very interesting to know. Today I was telling somebody I met, a nurse leader, I said, you do one audit when you go back. So I am giving that idea to all of you also. Just go and look at the respiratory rate documented in all your patients. You might be surprised that maximum of your respiratory rate are either 16 or 17 or 18. And it's very interesting to note also when patient actually, when their met is being called, it is good to deep dive and do an audit to see which parameter changed that the nurses called for the RRT or the MET. This is my hypothesis. You may find nurses are not calling anyone because the respiratory rate changed. Maybe something else changed. But science says respiratory rate is the first vital signs to shift when something goes wrong in our body because it immediately reacts to your pH. When anything goes wrong inside our body reacts. The acid base balance shifts. And when the acid base balance shifts, your respiratory rate can change based on whatever is the, you know, sickness or illness that's going inside. And it's not only it, there is enough literature evidence available that respiratory rate is probably the most inaccurately monitored vital signs. And EWS power is sitting in that respiratory rate. If you just watch, you will see that you can call the doctor and say, there is something wrong. The respiratory rate has changed for my patient. You may be able to catch that patient before some disaster happens. So I gave you some very, very basic idea to do these kind of, audits, find the evidence, talk to the nurses and say, what happens when you're doing EWS every day for all patients? Sometimes we become so used to it. Then we don't pay attention to whatever that it becomes very automatic. So my request to all the nurses is that not a single day, not a single shift is never as usual. Our eyes, ears, our brain should be always alert to think, what am I doing? What does this number mean for my patient? EWS actually has come as a very useful tool. Now, please don't look at EWS as something that the accreditation body is asking. Is actually a very important safety tool, correct? So I really hope some of you should go back and look at what is the practice of the nurses. This will really really help. Now before it is 8:05, before we sign off, I just want to show you something. Just for your information, I want to show that Annie has released his first publication. This is available on Amazon. This is our first publication called Learning Ignited from Errors. It is called Life. 288 pages. It's available on Amazon. This is a collection of 100 safety events. Took years to bring to this level, but it is definitely a wealth of incidents there that has happened. And if there are 100 things that we can discuss and learn, each nurse can prevent those 100 events happening in your practice. Multiply that by the number of nurses who will go through this book. Educators can use this to convert them into simulation learning. All faculties in the colleges, you can look at different, even they are segregated into, in the index, it is, if you look at the index, you will see that it is in alphabetical order. Plus, if there is a IPSG involved, it will be written inside whether which IPSG was involved as well. So I really request all of you to please check out this book on the website. And before I say once again a reminder for so thank you everyone. And I can say I think Captain Ajita is here. So would you like to say something, Ajita, before we wind up?
Hi, ma'am. Yeah.
Hi.
I was listening to you in between, I should say, because I had a lot of phone calls.
Okay.
But anyways, hi, Dr. Devinder. Very nice topic, and we dealt with. And there's significant number of participants as well, and it's a very relevant topic because I guess this, if this early warning score is something which the nurses understand really and put it into practice, this is one thing which can actually reduce the number of cardiac events, cardiac arrests rather, and save a lot of patients because we can reach out to them at the earliest. Now there are many equipments which are coming new, which can predict it much earlier than somebody really assessing it, human assessment. But still, by and large, in our Indian hospitals, I'm sure very, very few hospitals are only using those uh, devices. But our nurses will have no way but to learn and be proficient at this. And maybe those who are teaching them should teach them in the right way. That's what I feel, because this is all done as Ms. Sangam said. Everything is done for fulfilling accreditation requirements. So we say, even if it is that, what is wrong in that? But it is used for, sort of eyewash thing and just for the heck of it. And the nurses don't understand and they don't use it. And even if they all understand, there are human elements in that, right? So their eyes might miss it, or their brain may not focus on what they see. So these variables are still there when we talk about the results, but nothing can justify not knowing it. So it's very important that the nurses know about early warning signs, how to apply this knowledge into practice when they deal with patients. So this is a lifesaver. In short, it is equivalent as you learn CPR. It is just equivalent to that, actually. So this should be compulsory for every nurse, and even in teaching institutions, the students, because we just teach them about the TPR chart, right? So that TPR chart is a different version of this, but in here we are incorporating the knowledge as well, right? So that is a great thing. And thank you for bringing out this topic and talking about it. And thank you so much. Thank you. I need to take this call too. Okay, thank you. Thank you for that.
Thank you, Ajita. Thank you very much, Dr. Davinder. Thank you so much. And somebody wrote here, I got the book, Life. Thank you. So go ahead and use life to save lives. I can only,
Thank you, ma'am.
that's why it is called as life. And thanks a lot for throwing light on a very, very important topic. I hope it has influenced the people sitting here a different way of looking at EWS and making a difference to patient safety. Thank you, everyone, and take care and good night. And we will see you next month about safety of intra-hospital transfer of non-ventilated patient, an interesting quality improvement project. We will keep you posted. See you in March.
Thank you, ma'am. Thank you so much, ma'am.
Thank you. Bye bye.